I'm Dr. Brian Flynn. I'm from the University of Colorado. This is a talk on functional and reconstructive urology. So we're going to define functional urology, reconstructive urology, why another specialty or rebrand, and hopefully have a little bit of time for some questions and some insight from the group. So if everyone can look at this quickly, this is a slide when I kind of started with this journey on functional urology I'd sent out to the group. So what is it? It's functional urology, pharmacologic treatment, medical treatment, surgical treatment, or the most common answer I got would be E, a form of quackery, holistic, alternative, integrative medicine. So I think when people hear the word functional, they think it's code for dysfunctional. So before we define functional urology, we have to say, what is urology? I think all of us had that look at least once from maybe an in-law saying, what do you do? I'm a urologist. Neurologist? No, urologist. Neurologist? No, urology. Oh, okay. So we all have been dealing with this for a long time, and we've gotten over being called penis doctors and other things. And so we have very small egos because of all this abuse we've taken. But urology takes care of the urinary tract and the genital tract. Okay, it's not hard. We do a lot more than just the male genitals. What about subspecialties, right? There's so many subspecialties out there in urology. Do we really need another subspecialty? And when you define a subspecialty and what does a genital urinary reconstructive surgeon do, I think what I hear most commonly from friends, if I introduce myself that way, is, oh, you're a genital surgeon, or you do transgender care or penis surgery. And it goes on and on. Everyone knows you're a surgeon, but maybe they only know half of what you do. So the TAU looked at this and said reconstructive urology is a highly specialized field of male urology. You don't even see the word female in there, that restores structure and function to the genital urinary tract. That's from Wikipedia, actually. Well, how many subspecialties do we even really have in urology? We only have two that are board certified. So we have FPMRS, which is now rebranded to urogynecology and reconstructive pelvic surgery. We have pediatric urology. So we really only have two boards in urology. Do we need more boards? Do we even need two boards? This has been very controversial in urology. So if you look at what happened with FPMRS, this was a 30-year deal where we eventually got to the point of female urology merged with urogynecology, then had FPMRS to only have the whole thing blow up, and now it's called urogynecology and reconstructive pelvic surgery. Because for people that have a male practice, they didn't want to be identified as urogynecologists, and vice versa. So if you go to the subspecialty societies, which society sort of defines this the best, and do any of them really? I think probably the EAU and the ICS are probably the two best. And this is right from their website in EAU section of functional and female urology, kind of right next to reconstructive urology. And that's kind of the two worlds that I've lived in for the last 20 plus years. I want to give a shout out to three people who've helped me a lot in this project. Dave Crawford was the first person to give me a platform to speak on this at Future Directions in Urology. I was able to speak a second time at Ryan Terlecki's meeting, Urology Today. And Urology Today, next to this meeting, of course, is the second best meeting in urology outside of the AUA. But for people in the community and for APPs, this is a really engaging meeting in Asheville, North Carolina that Ryan runs. And of course, the Jackson Hole Urology Seminars. 43 years this meeting's been going. This is the longest running meeting next to the AUA and the state societies in the United States. So kudos to these three people, really for listening to me, and my wife Amy back there for listening to me endlessly on this topic. So after the meeting in Future Directions, we came up with some consensus statements. And the idea of that meeting is you come up with some ideas, you put them in a time capsule, you open it up 5 years later and see how you did. So in 5 years, we hope that functional and reconstructive urology will continue to expand the specialty and advance the care of pelvic floor disorders in men and women. Okay, neurogenic, non-neurogenic, male, female, young, old. If you put in genital reconstruction, right, so I'm trying to rebrand here. So I talked to my friends, Okay, Ryan, David, Fernando, talk to the subspecialty societies, but we have to talk to Google, right? So if you type in genital reconstruction, this is what you get. You get surgery from male to female, you get top and bottom surgery, you get a very much a surgical picture, a lot of surgery. If you type in functional urology, you get functional medicine, functional urology definition. It's maybe a little less clear what this is, but you don't see surgery really anywhere on this slide. So what does a functional urologist do? Okay, is it non-operative surgery? I had a person recently in the leadership at my hospital say, I'm not sure why you want to use that term, because my understanding is that it doesn't involve surgery. It does involve surgery, but also embraces things outside of surgery. Okay, functional medicine, I think that term, you go to the functional medicine podcast. Everyone go ahead and Google that on your Spotify. There's a podcast on that. And functional medicine is similarly is kind of rebranding. So think of what was quackery, what was alternative medicine, integrative medicine is now functional medicine. So there's a lot of rebranding going on. And the question is, do you need a rebrand? And do we want to be known as doctors or real doctors, right? So you'll hear, on certain podcasts now, people went from using your healthcare provider to a term that's even different than that, because there's a lot of naturopaths and other people treating patients. So I think if allopaths and osteopaths don't embrace a lot of the natural stuff, others will. And so this is a slide that I think many people have seen in the past. When they think of functional medicine, they think of sort of the brain, the spinal cord, the microbiome, and connections in those regards. But it also involves surgery, robotic surgery as it applies to functional and reconstructive urology. So here's an article from the European Urology Journal. And I certainly do surgery. This is a slide on our robotic reconstructive urology program. We've done over 500 robotic reconstructive cases since we started the program 10 years ago. So we're trying to continue with what we're doing, but also bring in other things into the program. So what is functional urology? It addresses benign conditions of the urinary tract. It addresses dysfunction. It addresses disorders that impact quality of life, and we manage both surgical and non-surgical. So we're not the first person to rebrand. I'm sure many of you remember some of these symbols. If you're old enough, you can see that Apple symbol from 1977. That went from complex to simple, the McDonald's rebranding, and even Starbucks. So everybody is capable of a rebrand. And when do you need a rebrand? Well, you need a rebrand when people don't know what you do, people can't find you, you don't have a clear message, and you want to really target the patients you want. I say to a lot of my residents and fellows, if you let your practice become everything what everyone else doesn't do in the group you're joining, that's what it'll become. So you have to create your identity and your brand so patients can find you. So if you have an outdated website, you probably need a rebrand. If your position on your website doesn't express what you're doing currently, you need a rebrand. And if you're targeting the wrong audience, so people often get out in practice and they're frustrated because maybe they're not doing enough robotics. Maybe they need robotics in their brand, or maybe they're not doing enough incontinence work, and how do they target that? So this is just a funny slide I made probably 10 minutes ago, but people rebrand in politics, right? So look at this slide, right? And you can think, where are we at politically in this country? And depending on which side you're on, you can, move things around. Both slides are accurate representations of how people vote in this country, but it's all how it's being presented to the viewer. Okay, so we went from general urology to female urology to FPMRS to now functional and reconstructive urology. And you might say, why not just go with functional urology, right? What's wrong with that? Well, we had the abbreviation FU in the past, and I just don't think it really resonates real well. So I remember talking to my family about this. I'm like, I need another letter there. I can't just do FU. We need another letter. So hence functional and reconstructive urology. So Canada is a little bit ahead of us on this. This is an article from the Canadian Urologic Journal. Urologists should be the experts of the lower urinary tract. Physicians in these practices are now embracing APPs, nurse practitioners, even family medicine providers, because the number of patients that we can potentially treat in a urology clinic, especially if you bring in something like men's health, it's going to be overwhelming. It's going to be more than what a urologist can handle. And how do we manage this influx of patients? Well, you can come up with an integrated model that's going to embrace long and short-term care, improve access to your patients, and really by having physicians lead in this space with APPs, we can hang on to the practice of urology. Okay, this is a clinic in Alberta, Canada, that I've been modeling some of the things that I'm trying to do. And think about this as being a urology clinic that's specializing in voiding dysfunction, incontinence, bladder disorders, and prostate disorders. Everything that's not cancer, stone, or peds. And so this is a slide from business and urology and looking at the business side and what your priorities should be. So the first thing you want to do is enhance the patient experience, improve physician wellness. We're hearing so much about burnout, and a lot of burnout comes from not seeing the patients you want, not having your practice function the way you want. Third thing, optimize the operational efficiency of your practice, increase in communication, bring research into the practice. And then this is just an example to build a new program in men's health, but the same thing can be done for FRU or for robotics or whatever really your interest is in. And not only can you do that in a clinic, you could also do it in a department or in a division for those that are in academic medicine and trying to rebrand or reshuffle their departments. If you're a chair or a vice chair, you want to improve the clinic experience, right? Decrease the wait time. You want to have the urologist be satisfied and the patient to be satisfied so people aren't getting burned out. You want to have better access for the patients, higher quality of care. And then you want to be able to involve your trainees for those in academic medicine. How do we rebrand? How do we shuffle? How do we move from the hospital out into the community without leaving some of our core missions for education behind? Senator Hirshhorn, who's been mentoring me on this as well, received the first endowed chair in North American functional urology. And I had the pleasure of interviewing him recently for Grand Rounds in Urology. That's going to show up on the Learning Center. And I encourage people to look at that. But Chris Chappell, Alan Ween, and others have been leading in this space for a long time. This is something I'm doing at the University of Colorado. I've been fortunate enough to receive some funding to develop a functional and reconstructive urology clinic there. And we're getting very close to seeing this come to fruition. For people who want to learn more, there's textbooks on functional urology. Okay, this is not a term that I invented. I've had people say, did you invent that term? No, of course not. This book is from 20 years ago. Okay, you can go to Grand Rounds in Urology. Grand Rounds in Urology is trying to expand beyond cancer and have other learning centers for functional and reconstructive urology. So that's going to be hopefully coming up in the next month or so, I'm hearing from Bill back there, perhaps. And this is going to be the learning center that I'm going to run on the website with the help of Dave Crawford and others. If people have ideas for the learning center, want to contribute content, please reach out. So I'm going to finish up here with just a couple slides. Functional urology includes urinary incontinence treatment in men, incontinence treatment in women, neurogenic disorders, non-neurogenic disorders, infections, inflammation, BPH, are all of the above. And I would argue that it's all of the above. So think of everything that's not cancer, stone, or peds. And the rebranding is necessary. It's happened in many industries. It certainly has happened in the medical industry. And this is really a consolidation of everything that's outside of oncology, stone, and peds, because we really, in big departments, don't have representation. So think about the men's health area come together with female urology, functional urology, and a lot of the benign providers in that urology clinic all coming under one roof. So the management of incontinence can be done by urologists, both in men and women. Functional and reconstructive urologists should be experts in this space and continue to lead. Thank you.